Good morning, Roger. You look a bit tired today. Tell me what brought you in.
Yeah, I've been feeling exhausted lately. Not the normal long day kind of tired. It's like I wake up already drained.
I see. How long has this been going on?
Maybe 6 or 7 months. It's been getting worse recently.
All right. Anything else you've noticed?
My wife keeps complaining about my snoring. Says it's gotten really loud. Sometimes she even nudges me because I stop breathing for a second.
And during the day?
Honestly, I'm sleepy all the time. I almost nodded off at my desk last week. It's embarrassing.
That must be frustrating. Any other changes you've noticed in your body?
Well, this might sound weird, but my shoes don't fit anymore. I thought maybe they shrank or something, but I tried buying the same size and it's still tight.
Your shoes. Has your weight changed?
Not really. My weight's the same, but my feet feel bigger. I don't know how to explain it.
You're doing the right thing by mentioning it. Anything else that feels different?
Just this overall heaviness, like my body is working harder than it should.
Roger, I'd like to ask a few questions about your family's health. It helps me understand the bigger picture. Has anyone in your family had hormonal or endocrine problems?
My dad has type 2 diabetes, but that's about it. No thyroid or hormone issues that I know of.
Right. Anyone ever diagnosed with pituitary tumors or other brain tumors?
No, nothing like that in the family.
All right, Roger. Let's go through a quick physical exam.
Roger appears tired, with mild periorbital puffiness, and a slightly coarse facial appearance. Vital signs showed: blood pressure mildly elevated, heart rate normal, respiratory rate normal, BMI stable, not obese. Head and face examination revealed: frontal contour forehead appears slightly prominent. Jaw alignment, lower jaw subtly protruding. Lips and nose mildly thickened. Tongue enlarged when he opens his mouth. Neck examination revealed: airway thickened soft tissues around the neck. Hands and feet examination revealed: hands broad palms, thick fingers, rings fitting tightly. Feet, widened forefoot, shoe size mismatch. Joints mild stiffness on palpation.
Roger, based on what you told me and what I found during your examination, I'd like to request some blood tests. These will help me understand what's causing your symptoms and guide us in the right direction.
All right, doctor. What kind of tests do I need?
The doctor orders a set of laboratory investigations to evaluate Roger's hormonal and metabolic status, hormonal profile, IGF-1 level, growth hormone, GH, oral glucose tolerance test, GH suppression, prolactin, TSH and free T4, cortisol and ACTH, metabolic profile, fasting glucose and HbA1c, lipid profile, liver and kidney function tests. Additional tests: serum calcium and phosphate, CBC, urinalysis. To further evaluate Roger's condition, the doctor requests a set of radiological investigations. These imaging studies help visualize the pituitary gland, assess surrounding structures, and detect any complications related to growth hormone excess. The first test is a pituitary MRI, the gold standard imaging technique. It allows precise visualization of the pituitary gland and helps identify the presence, size, and extent of a pituitary adenoma. A CT scan of the skull base is also requested. This helps evaluate bony changes and sinus enlargement, which are common in long-standing acromegaly. Mixed visual field testing is performed to check for compression of the optic chiasm, a possible consequence of a growing pituitary mass. And finally, a chest X-ray may be done when clinically indicated to assess heart size and look for any lung-related changes. These radiological investigations, together with the laboratory results, provide a complete diagnostic picture and guide the next steps in Roger's management.
That sounds good, Doctor. I'm ready to do whatever tests you think are necessary.
Great. We'll get these done today, and once the results are back, we'll go through them together. Roger, based on your hormone levels and the MRI findings, we can confirm that you have acromegaly caused by a functioning pituitary adenoma. The tumor is producing excess growth hormone, which explains the changes you've been experiencing.
So, it's a tumor?
Yes, but it's a benign tumor, meaning it's not cancer. And the good news is that we have very effective treatment options, including surgery, medication, and sometimes radiotherapy. We'll discuss the best approach for you together. Roger, now that we've confirmed your diagnosis, I'd like to talk with you about the treatment options. The goal is to normalize your hormone levels, control the tumor, and prevent long-term complications.
I understand, Doctor. What are my options?
The first-line treatment for your type of tumor is transsphenoidal pituitary surgery. A neurosurgeon removes the adenoma through the nose without opening the skull. Because your tumor is small and not invading nearby structures, the chances of success are very high.
Is it dangerous?
Every surgery has risks, but this one is considered safe and minimally invasive. Most patients go home within a couple of days. If surgery doesn't fully normalize your hormone levels, or if you prefer to delay it, we have effective medications, somatostatin analogs, reduce GH secretion. GH receptor blockers prevent GH from acting on tissues. Dopamine agonists, helpful in some cases. These medications can be used alone or after surgery.
So even if surgery doesn't fix everything, there are still options?
Absolutely. We have multiple ways to control the disease. Radiotherapy is usually reserved for cases where surgery and medication don't fully control hormone levels. It works slowly over time, but it's a reliable backup option.
I see. So surgery first, then medication if needed?
Exactly. And we'll follow your hormone levels closely to make sure you're improving.
With a clear treatment plan in place, Roger begins the next phase of his journey, aiming for hormonal control, symptom relief, and a return to normal quality of life. Roger came with symptoms that had slowly crept into his life: fatigue, snoring, daytime sleepiness, and noticeable changes in his hands, feet, and facial features. These clinical signs raised suspicion of acromegaly, prompting a focused hormonal evaluation. His tests confirmed the diagnosis. IGF-1 was markedly elevated, and his growth hormone did not suppress during the glucose tolerance test. Imaging completed the picture, revealing a small 8 mm pituitary adenoma without optic chiasm compression or invasive features. With the cause identified, the treatment plan became clear. The first-line option is transsphenoidal pituitary surgery, offering a high chance of cure. If needed, medical therapy, including somatostatin analogs or GH receptor blockers, can further control hormone levels, with radiotherapy reserved for resistant cases. Roger now moves forward with a clear diagnosis, a structured plan, and an excellent outlook for recovery. Acromegaly is a rare hormonal disorder, most often caused by a growth hormone secreting pituitary adenoma. It typically develops slowly, with symptoms appearing over several years, and is most commonly diagnosed in middle age. Ectopic hormone secretion is possible but extremely uncommon. Acromegaly produces a wide range of physical and systemic changes. Patients often develop enlarged hands, feet, and facial features, along with soft tissue swelling and sleep-related breathing problems. Metabolic complications such as insulin resistance are common, and joint pain may significantly affect quality of life. Diagnosis begins with measuring IGF-1, which is typically elevated. A glucose tolerance test confirms the condition when growth hormone fails to suppress. MRI imaging identifies the pituitary adenoma, while additional hormonal and metabolic tests help assess the broader impact of the disease. Treatment focuses on normalizing hormone levels and controlling tumor growth. Transsphenoidal surgery is the preferred first-line option. If hormone levels remain elevated, medical therapy can provide effective control, and radiotherapy is reserved for resistant cases. Long-term monitoring ensures sustained remission.